Imagine undergoing like a major medical procedure, going home to recover, and then being told that a 90% complication rate is essentially standard.
Right, which is, it's staggering when you put it like that.
It really is. Like if you were getting knee surgery, that number would be a massive scandal. People would freak out.
Yeah.
But in the realm of first-time vaginal births, up to 90% of individuals will experience some form of perineal trauma.
Yeah, tears, grazes, episiotomies, you name it.
Exactly. We are talking about an area of the body subjected to just intense mechanical stress, and yet the diagnostic landscape for figuring out if your recovery is actually on track is, well, it's incredibly murky.
It's so murky because the signals your body sends after these kinds of procedures are highly complex. You were dealing with an internal mucosal environment that's constantly in motion.
It's fluctuating with hormones, it's exposed to varying types of bacteria. So differentiating between the kind of messy reality of normal tissue repair and an active complication that requires actually understanding the biological mechanisms beneath the surface.
And that is the core mission of this deep dive. We're taking a highly specific look at decoding those exact signals after a gynecological procedure or childbirth. Basically, we are answering one critical question for you today. How do you know if your healing is delayed?
Which is such a vital question.
It is. So to build a really comprehensive picture for you, we are pulling from clinical guidelines from the Royal College of Obstetricians and Gynecologists, NHS Trust patient protocols, clinical trial data on postpartum trauma, and some pretty fascinating medical case reports.
Because the goal here is to equip you with the knowledge to read your own physical signs accurately. I mean, recovering at home, especially if you're potentially caring for a newborn on top of it, places you in a very vulnerable position.
Oh, absolutely. Every twinge or unusual physical presentation can just trigger instant anxiety. Yeah, exactly. But by understanding the underlying cellular processes, you can actually transform that anxiety into informed observation. Separating the uncomfortable but totally expected phases of recovery from the genuine warning signs that actually require clinical intervention.
So I feel like before we can spot the warning signs, we have to establish the baseline, right? Like, what does normal healing actually look and feel like?
Right, we need a baseline. So the standard timeline for recovery from perineal tears or, surgical interventions, it's generally 4 to 6 weeks.
Okay, 4 to 6 weeks.
Yeah. And the key indicator during this window is really the trajectory of your symptoms. So pain and swelling should be on a steady downward gradient.
Meaning it should be getting progressively better, even if it's slow.
Exactly. The direction of the trend matters way more than the daily intensity. Tissue repair is an inflammatory process by design, so you will definitely experience discomfort. But if you, graph that discomfort, the line should point down over time. And alongside that downward trend, you're going to encounter physical artifacts of the healing process that can appear super alarming, but are actually entirely routine.
Like what's an example of an artifact?
So finding small pieces of dissolvable stitches in your underwear after a week or two, that is a perfect example. People panic, but it's totally normal.
Because those stitches are engineered to break down, right? Like that's the whole point.
That is the whole point.
Yeah.
They're composed of synthetic polymers that undergo hydrolysis.
Hydrolysis.
Yeah. Basically, the water in your body's tissues gradually breaks the chemical bonds of the stitch.
Mm-hmm.
So as the surrounding tissue knits together and gets its tensile strength back, the stitch itself loses its structural integrity and just fragments.
Oh, wow. So it's basically melting.
Exactly. Seeing those fragments means the local macrophages. Those are the white blood cells that clean up cellular debris. It means they and the local environment are functioning exactly as intended.
That's actually really reassuring. The guidelines also note that vaginal bleeding mimicking a light period is standard for a few weeks, as the vascular network repairs itself. But the visual presentation of that healing gets far more intricate when we look at specific interventions.
Oh, definitely.
Like the LLETZ procedure, for example, where abnormal cervical cells are removed. Our sources mention that following that procedure, the cervix forms a scab, but then about 10 days later, you might experience a discharge that looks remarkably like dark coffee granules.
Right, which sounds terrifying if you don't know what it is.
Yeah, I would definitely panic.
But it's just biology. The biological environment dictates how a wound presents. So think about if you scrape your knee on the sidewalk.
You just get a dry scab.
Exactly. The blood and plasma dry out in the open air, and that forms a hard, crusty scab. But the cervix and the vaginal canal, those are mucosal tissues. They lack a keratinized outer layer, and they're kept continuously moist by cervical mucus and transudate.
Right, so it's a completely different environment.
Yeah, so a wound in that ecosystem literally cannot dehydrate into a hard crust.
So, I mean, does it form a totally different type of protective layer then?
It does. It forms what's called a soft Escher. So this is a slowly damp matrix of coagulated blood, fibrin, and healing tissue.
Kind of like a wet scab.
Essentially, yeah. And when the new epithelial layer underneath is finally robust enough, it sheds this Escher. But because the shed material is trapped in this moist, acidic environment, the iron in the old blood oxidizes.
Oh, and that's why it turns dark brown or black.
You got it. It mixes with normal vaginal secretions and exits the body looking literally like coffee grounds. It is the identical biological mechanism to a knee scab falling off. It's just adapted to a high moisture, low oxygen ecosystem.
So the appearance of that dark discharge at day 10, that isn't a sign of, like, new bleeding. It's actually the physical evidence that the first major stage of cellular repair has successfully completed.
Exactly. It is a milestone of progress, not a regression.
Okay, that makes so much sense. But when that mucosal ecosystem gets disrupted, the timeline obviously deviates. So now we need to look at the specific mechanisms of delayed healing, primarily the condition clinically known as dehiscence or perineal wound breakdown.
Right, dehiscence.
This is basically when the repaired tissue fails to hold, right, leaving an open or gaping wound.
Yeah, and tissue failure in this region generally comes down to two specific mechanisms. It's either mechanical pressure or biological degradation.
Let's start with mechanical.
So a hematoma is a prime example of mechanical pressure. If a blood vessel deep within the surgical site wasn't, fully cauterized or tears open, blood pools in the subcutaneous space.
Underneath the skin.
Exactly. And this accumulating fluid acts like a hydraulic press from the inside out. It places immense tension on the suture line until the tissue simply gives way.
Yikes. And what about the biological degradation?
That happens when bacteria overwhelm the site. The clinical red flags for an infection are highly specific. We are talking about pain that suddenly spikes, which reverses that downward trajectory we mentioned earlier.
Right, it gets worse instead of better.
Yes. Also severe swelling, localized hardness, and a fever of 100.4 degrees Fahrenheit or higher. We also see thick yellow or green discharge, which often has a really foul odor.
And those symptoms are basically the visible manifestation of your immune system just waging a systemic war, right?
Precisely. That sudden spike in pain and the severe localized swelling, that's caused by rapid vasodilation. Your blood vessels are opening wide to flood the area with leukocytes or white blood cells to fight the pathogens.
And the fever.
The fever is a systemic response. The hypothalamus raises your core body temperature to create a hostile environment for bacterial replication.
Wow. And the discharge.
That thick yellow or green discharge is purulent fluid. It is quite literally the accumulation of dead bacteria, destroyed tissue, and the spent white blood cells that basically sacrifice themselves at the site of the infection.
Okay, that is incredibly vivid but helpful. The guidelines also flag delayed hemorrhaging, which they define as soaking a full pad in an hour as a critical emergency. Because, if the tissue breakdown compromises a major blood vessel, the structural integrity of the entire repair is just lost.
Exactly. Which brings us to the clinical intervention for a dehisced infected wound.
Now, this is where I have a question on behalf of our listener. If a stitched wound suddenly gaps open, I feel like my instinctual response would be to demand a surgeon re-stitch it immediately.
Oh, of course.
It just seems like the most straightforward mechanical fix to a mechanical problem. Just stitch it back up. But the protocols strictly advise against primary closure in these scenarios. Why wouldn't a doctor just close it?
Because suturing an infected wound closed is biologically disastrous.
It's disastrous.
Literally. By pulling the edges of the tissue together and sealing them, you create a dark, warm, anaerobic pocket. You're essentially building an incubator for the trapped bacteria.
Oh, no.
Yeah. Without access to oxygen and topical drainage, that localized infection can rapidly evolve into a deep tissue abscess. Or worse, the bacteria can enter the bloodstream and trigger sepsis.
And furthermore, the sources point out that the tissue itself is already compromised at that point.
Exactly. Infected tissue becomes incredibly friable. The bacterial enzymes and the inflammatory response break down the collagen matrix, so it makes the tissue resemble wet tissue paper.
So it wouldn't even hold a stitch if they tried.
No. If a surgeon attempts to pass a needle and thread through it, the suture will simply slice right through the necrotic tissue. It just won't hold tension.
Right, so the protocol requires treating the infection first with targeted antibiotics. And then once the bacterial load is completely cleared, the body has to heal via what they call secondary intention.
Right. So primary intention is when two clean edges are sutured together from the start. Secondary intention forces the body to act as its own masonry team.
Masonry team.
Yeah, because the wound is left open, the base of the wound cavity must generate new granulation tissue, slowly filling the void from the bottom up.
Got it.
Once that highly vascular raw tissue reaches the surface level, epithelial cells can finally migrate across the top to seal it. It's a much slower process, and it requires meticulous hygiene, but it guarantees the infection is cleared and the resulting structural tissue is actually sound.
Okay, so secondary intention relies on the body generating that new granulation tissue at a perfectly calibrated rate. But sometimes, according to our deep dive research, the cellular signaling misfires, which leads to this crazy overhealing paradox.
Yes,
The clinical term is exuberant granulation tissue, though historically it's referred to as proud flesh.
I've always found that term interesting. But yes, proud flesh. It presents as bright red, raw, raised patches of fibrotic tissue that protrude past the boundaries of the original wound.
And it's super sensitive, right?
Profoundly sensitive. Because this tissue is densely packed with new capillaries, but it lacks a mature epithelial covering. So it bleeds with the absolute slightest friction, like wiping with toilet paper, and it causes this intense tearing or burning pain during intercourse or pelvic examinations.
To visualize this for you, imagine an emergency response team rushing to the site of a damaged building. They secure the perimeter, they start pouring concrete to fill the foundation. But their radios break.
Right.
So even after the foundation is perfectly level, they just keep pouring more and more concrete, blocking the construction workers who are supposed to build the roof. You end up with a useless, overflowing mound of raw material that actually prevents the final stage of structural repair.
That is a perfect analogy. The cellular signals dictating when to stop the proliferation phase simply fail to reach the fibroblasts and endothelial cells.
Why does that happen?
Often, this miscommunication is triggered by mechanical irritation. So if a tiny fragment of a synthetic stitch fails to dissolve and remains embedded in the tissue, your immune system recognizes it as a foreign invader.
Oh, so it just keeps attacking it.
Exactly. It continuously attempts to wall off the irritant by producing endless layers of granulation tissue.
So obviously, identifying and removing that embedded stitch fragment is step one. But if the tissue overgrowth persists, the primary treatment they use is chemical cauterization using a silver nitrate stick.
Yes, silver nitrate.
Which, reading about it, it looks like a matchstick, but instead of phosphorus, the tip is coated in a chemical compound that literally burns away the excessive tissue. Since it is burning the flesh, it sounds agonizing, yet the sources say it's completely painless. How is that possible?
It's fascinating. The biology of newly formed granulation tissue lacks a developed sensory nerve network. The body prioritizes building blood vessels first to supply oxygen and nutrients. The complex neural pathways take much longer to establish.
Oh, so there are literally no nerves there yet.
Right. When the clinician touches the silver nitrate to the proud flesh, it causes this instant chemical reaction that coagulates the cellular proteins, effectively destroying the overgrowth. But because there are no mature pain receptors in that specific patch of hyperproliferated tissue, the patient just feels pressure.
Maybe some mild warmth.
Yeah, perhaps a mild warmth, but absolutely no sharp pain. And the cauterization planes the surface flat, which finally allows the epithelial cells, the construction workers in your analogy, to finally migrate across and seal the site.
The medical texts introduce a really fascinating contradiction here regarding how hormones influence this whole process. So topical estrogen cream is frequently prescribed to accelerate slow wound healing, particularly for nursing mothers,
Yes.
because prolactin, the hormone responsible for milk production, naturally suppresses estrogen levels, leaving the vaginal and perineal tissues much drier and less elastic.
Right, which slows healing.
Exactly. But simultaneously, case reports note that applying topical estrogen is linked to a significantly higher incidence of developing exuberant granulation tissue. So it basically cures the delayed healing by causing overhealing. How does that make sense?
It really highlights the razor-thin margin of error in localized hormone signaling. So estrogen is a potent mitogen.
Mitogen, what's that?
It means it induces cell division. It binds to receptors in the vaginal mucosa and forcefully commands the cells to proliferate, synthesize collagen, and develop new blood vessels. So for a nursing mother with a stagnant wound cavity, That topical application provides the exact biochemical spark needed to restart the stalled healing process.
Right, it turns the emergency response team back on.
Exactly. But the local microenvironment can become hypersensitive. Because you're applying an exogenous, highly concentrated hormone directly to the wound bed, the cellular receptors can become completely oversaturated.
The estrogen signal just becomes deafening.
Yes. The cells rapidly build the necessary granulation tissue to close the gap. But the continuous presence of the topical estrogen keeps shouting the command to multiply. So the cells overshoot the runway, continuing to pile up raw tissue beyond the surface boundary.
Wow.
The treatment successfully solves the atrophy but artificially induces the proud flesh.
Which means it demands really precise clinical monitoring to, titrate the dosage as the tissue responds, balancing the need for cellular proliferation with the risk of that hypertrophic growth.
Absolutely.
So since maintaining a balanced cellular environment is clearly so critical, the way you physically manage the wound at home becomes your first line of defense. The actionable protocols emphasize strict environmental control.
They do. The NHS guidelines are definitive regarding hygiene. Utilize water only.
No soaps.
No soaps. Introducing soaps, shower gels, or perfumed products disrupts the natural acidic pH of the vaginal flora. That acidic environment is actually a primary defense mechanism against bacterial colonization.
So if you use soap,
Applying basic soaps neutralizes that defense, leaving the compromised tissue highly susceptible to the very infections that caused dehiscence in the first place.
the protocols also stress the importance of air drying rather than using a towel, because you want to eliminate physical friction that can shear off fragile new skin cells. And they suggest leaving underwear off at night to allow the area to remain dry, since, trapped moisture creates the perfect incubator for bacterial growth.
Exactly. And we must also address the internal mechanics, specifically bowel care. A predominant source of psychological distress postpartum is the fear that defecation will just rupture the surgical repair.
Oh, absolutely.
But physiologically, the normal peristaltic movement of opening your bowels does not generate enough localized tension to compromise healthy sutures.
But the mechanical force of straining changes the physics entirely, right?
Oh, completely. Straining dramatically increases intra-abdominal pressure. This pressure transfers downward, placing an immense mechanical load directly onto the pelvic floor and the perineal suture line.
So how do you avoid that?
To prevent this, the protocol necessitates consuming at least 2 liters of water daily and maximizing your fiber intake. The entire goal is to ensure the digestive process remains effortless, mitigating any internal hydraulic pressure on the healing tissue.
Okay, that makes sense. Now, looking at the clinical trials, they provide remarkable data on managing the inflammatory phases using temperature. The established protocol utilizes ice gel pads immediately following the trauma, but strictly mandates switching to warm compresses after 48 hours. Why the strict cutoff?
Well, the first 48 hours are dominated by the acute inflammatory response. The tissue is flooded with fluid, causing severe swelling and compressing local nerve endings, which basically registers as acute pain. Applying ice induces rapid vasoconstriction.
It shrinks the blood vessels.
Right. By shrinking the diameter of the blood vessels, you mechanically limit the volume of fluid and leukocytes entering the interstitial space. This curbs the severe edema and temporarily numbs the nerve endings.
But keeping the blood vessels constricted for too long deprives the tissue of the resources it needs for the next phase.
Exactly. The repair phase requires raw materials. Switching to warm compresses after the 48-hour mark induces vasodilation. Expanding the blood vessels flushes the stagnant inflammatory fluid out of the capillary beds and floods the area with fresh, oxygenated arterial blood, amino acids for collagen synthesis, and circulating immune cells to prevent secondary infections.
And to actively promote that blood flow, the clinical trials heavily advocate for using the Squeezy app to guide patients through Kegel exercises. Now, I have to ask, for anyone with a freshly stitched muscle tear, actively flexing that exact muscle feels deeply counterintuitive.
I know, it sounds awful.
Right. It seems like the equivalent of aggressively stretching a torn hamstring the day after surgery. Doesn't that risk tearing the stitches?
The apprehension is completely logical, but we have to reframe how we view pelvic floor contractions here. We're not aiming for maximum load-bearing tension. We're utilizing the muscle as a physiological pump.
Okay, describe the fluid dynamics of that pump for us.
Sure. So picture the damaged pelvic floor tissue as a saturated sponge. Following the trauma, the interstitial spaces between the muscle fibers are engorged with stagnant lymph fluid, cellular debris, and inflammatory cytokines.
Okay, gross, but I'm with you.
When you perform a gentle, controlled Kegel contraction, you are compressing that sponge. The mechanical action forces the stagnant inflammatory fluid out of the local tissue and into the lymphatic drainage system.
Oh, so you physically squeeze the waste out.
Exactly. Then, upon the relaxation phase of the Kegel, the muscle fibers expand. This expansion creates a localized negative pressure gradient, drawing in a surge of fresh, highly oxygenated arterial blood.
Wow.
Yeah, by repeating this gentle contraction and relaxation cycle, you are manually pumping the necessary biological building blocks directly into the wound site while simultaneously flushing away the waste products that cause localized swelling and pain.
There's also a structural benefit to the movement regarding how the scar tissue forms, right?
Yes, fibroblasts lay down new collagen fibers in a somewhat chaotic web. Gentle movement and contraction during the healing phase apply mild mechanical stress to those fibers.
And how does the body react to that?
The body responds to that stress by aligning the collagen parallel to the lines of tension. This ensures the resulting scar tissue remains flexible, functional, and integrated with the surrounding muscle, rather than forming a tight, restrictive, and painful nodule. Controlled movement is essentially physical therapy for the cellular matrix.
That is amazing. We have mapped out a highly intricate biological landscape today. We established the 4 to 6 week baseline, noting that the downward trajectory of pain and the strange visual artifacts like shedding polymer stitches and oxidized mucosal eschers are actually evidence of a functioning cellular repair system.
We examined the severe red flags of dehiscence, tracing how unmanaged bacterial loads lead to systemic immune responses, and exploring the grueling but necessary mechanics of secondary intention healing when primary closure is impossible.
We navigated the estrogen paradox and the phenomenon of exuberant granulation tissue, where the cellular signals to multiply just weren't shut off, and how a chemical reaction with a silver nitrate stick basically resets the surface. And we detailed the rigorous home protocols relying on temperature manipulation, strict hydration, and the physiological pumping action of targeted muscle contractions to dictate the healing environment.
Right. And by understanding the why and the how behind these processes, you transition from just a passive observer of your symptoms to an active participant in your recovery.
Absolutely. But, the process of monitoring your pelvic health does not end when the stitches dissolve and the surface tissue seals. I want to leave you with a final thought regarding the long-term architecture of your body.
The clinical data reveals a pretty sobering reality regarding severe third, fourth degree tears, which extend into or completely through the anal sphincter complex. During the initial 6-week postpartum window, the surface mucosa might appear flawlessly healed, and normal function may seem completely restored. However, that outward healing can mask profound micro tears in the underlying musculature and subtle damage to the pudendal nerve network.
Damage that remains entirely asymptomatic for decades.
Precisely. In your 20s and 30s, your peak estrogen levels ensure maximum tissue elasticity, and the surrounding undamaged pelvic floor muscles easily compensate for the localized weakness. You feel entirely normal, but as you enter perimenopause and menopause, that systemic estrogen drops drastically.
And that's when the issues start.
The compensatory muscles lose their mass, the connective tissue loses its elasticity, and suddenly the architectural support network collapses.
So a birth injury sustained 30 years prior suddenly manifests as severe urinary or fecal incontinence.
The compensation mechanisms simply run out of runway. It reinforces that understanding your pelvic floor is a lifelong endeavor. If you experience significant trauma, engaging in consistent pelvic floor physical therapy and recognizing that symptoms can emerge decades later is absolutely paramount. Your recovery isn't just about surviving the immediate postpartum period. It is about aggressively protecting your quality of life for the decades that follow.
The superficial wound closing is really only the first chapter of the story. Trust your instincts, advocate for your long-term health, and never hesitate to seek out the specialists who can help you read the signals your body is sending. Thank you for joining us on this deep dive.